Good morning, everyone. My name is Mahandeep Singh, and I come to you live from the Department of Cardiovascular Diseases at Mayo Clinic in Rochester. And today is my distinct pleasure and privilege to have Dr. Mohammad Adnan Al Kholi, who is my friend, my partner, and also colleague in the cath lab. And he will present today on a very interesting and controversial topic of left atrial appendage closure for stroke prevention, especially in patients with non-valvular atrial fibrillation. Dr. Al Kholi is published extensively, more than 450 publications. He's the deputy editor of JACC Intervention. He's been recently nominated to be our vice chair for strategic innovations. And I just want to read a line of his summary that will summarize his vision. He says that he's passionate about bringing purpose and precision to research and translating it to impactful innovation. And that's what he's been doing in the field, not only of left atrial appendage closure, but various other interventions done in the cath lab and beyond. So, with that introduction, I will hand it over to Dr. Al Kholi, who will talk about LA appendage closure.
Thank you very much, Mandeep. It's a pleasure to be with you here today. Good morning, everyone. Thank you for joining us. Really a pleasure to be with you. I have a couple of disclosures to note here. And what I'm hoping to achieve today is to share with you a little bit of background about this whole field of left atrial appendage closure, its history, how the field has evolved, what kind of literature is out there to support this procedure, and what are the remaining challenges that we are attempting to address yet as of now. So I thought I'll start with a couple questions just to warm up today. So you will have a choice to respond through an audience response to 4 questions. No hard feelings, just do your best and see how we can go around this. The first question is, in randomized clinical trials that supported left atrial appendage closure, when the procedure was compared with warfarin, LAAC was associated with lower rates of ischemic strokes, lower rates of hemorrhagic strokes, higher rates of all-cause mortality, or higher rates of cardiovascular mortality. Please go ahead and vote. We're trialing this Zoom voting system now for these webinars, so hopefully it'll be effective. We'll give it a few more seconds. I see the votes are coming in. All right, I think we have enough votes to move to the next questions. And we'll come back and address those questions at the end after we share the background of them. I'm not sure if any of the audience is interested in taking medical boards, but this is a common question, very fair question for the board. As of now, LAAC is supported by what class indication in US guidelines, i.e. ACC, AHA, HRS guidelines? Is it 1B, 2A, 2B, or class 3 recommendation? There's a little bit of subtlety in the questions because the most recent guidelines were published just at the beginning of 2024, and there was a change from the prior 2019 guidelines. Okay, I think we have enough responses. We'll move to the next question. So this is a very important question for practice because we get asked this a lot. If a patient undergoes left atrial appendage closure, do they always have to be on some sort of anticoagulation for some period of time after the procedure, 6 weeks, 3 months, or not? That's not a mandatory thing anymore. Please go ahead and vote. This is also an evolving question. That's why I picked it for this audience. Okay, last question. We know that there is certain incidence of peridevice leak after the procedure. The management of those leaks has been controversial. So look at this question and answer if you think that large leaks matter, they're associated with adverse event, or if you believe even small leaks are associated with adverse events. All right, I think we've gotten enough responses for that. So after this quick warm up, let's go through the plan. So we're gonna talk about the history and rationale for left atrial appendage closure. Then we'll go over a little bit of data without overwhelming you with the huge literature, and then we'll go for remaining questions. Okay. So let's build up this story. We know that atrial fibrillation is a growing epidemic, and if you look at the most conservative estimates that were published a few years ago, you would note that we have somewhere between at least 10 million people with atrial fibrillation in the United States now. And we also have parallel literature suggesting that patients who are being admitted with stroke, we see more and more of those patients who have atrial fibrillation, all suggesting that this is a growing silent epidemic in the United States. We also know for a fact that atrial fibrillation related strokes are more disabling and more fatal than non-atrial fibrillation related strokes. So the same patients, same characteristics, have the same size stroke or similar presentation, they will do worse if they had atrial fibrillation for a variety of reasons. We also know that oral anticoagulation is effective in reducing stroke and atrial fibrillation. However, it is not well utilized, and even in contemporary practice, up to 50% of patients either do not go on blood thinners for various reasons or drop it after a year or two of usage because of side effects. This is another study just representing the same thing, showing that even with DOAC, not with warfarin, because now we're using DOAC for most patients, even with DOAC, the compliance remains poor in the general population. And this is kind of intuitive. If you have poor compliance, you're really not getting much of stroke protection. So this study nicely showed that once you discontinue oral anticoagulation, your stroke risk goes back up as if you were not really on it to start with. So that takes us to this unmet need. So we know stroke in AFib is bad. AFib is becoming an epidemic, and we have more and more population at risk. We know blood thinners work, but we can't really use them effectively because they have side effects. So that leads us to this unmet need. Can we do something else? This, I would say, landmark study, even though it was a meta-analysis by Blackshear in 1991, documented that when you look at patients who have thrombus detected within the heart, if you have non-valvular atrial fibrillation, 91% of those thrombi were detected within the body of the left atrial appendage. Why is that important? Is because if you actually have atrial fibrillation related to mitral stenosis, then the thrombi could be in the body of the left atrium or in the body of the left atrial appendage, 50-50 split. That's why left atrial appendage closure is not recommended in patients who have mitral stenosis related AFib. That's where non-valvular AFib comes from. So that's the rationale. If we find most of the thrombi in the body of the left atrial appendage, can we actually find a way to close this appendage and reduce that risk? And this is just a schematic of the legacy Watchman 2.5 device at the ostium of the appendage. And this is an autopsy slide showing how that looks in actual tissue. So now that's how this whole field came about. It really came from unmet need and then an observation that a lot of thrombi form in the appendage and maybe closing it will be useful. So what kind of data we have? Just so you remember this number, There are only 3 randomized clinical trials ever that have been done to compare left atrial appendage closure against blood thinners. The first of which, I'm going to combine the two because the two studies were done as complementary to each other, and most of the time their data are presented in a pooled fashion. So Protect AFib and Prevail, both of those trials have randomized patients to getting warfarin or receiving the Watchman device. And then a comparison was done at up to 5 years. And you could see here the efficacy endpoint revolved around strokes, and there were some other endpoints related to death and major bleeding. So a few things here. One, in terms of efficacy, which has to do with all-cause stroke, there was really not much of a difference between receiving the warfarin medication or receiving the Watchman device. Nothing, no difference at all between all-cause stroke. However, as they say, the devil is always in the details. That, if you look at the subtype of stroke, there was a major difference between the two arms. There was a lot less hemorrhagic strokes in patients who received the Watchman, intuitively, because we were not giving them blood thinners. And there was actually not statistically significant, but a pretty considerable increase in ischemic stroke in patients who received the Watchman versus those who received the warfarin. So all-cause stroke is no different between the two arms, but the type of stroke matters. There were more ischemic strokes with the Watchman device and more hemorrhagic strokes with the warfarin treatment. There was also less all-cause death and cardiovascular death in the Watchman arm. Kind of difficult to discern why, but probably some of it is derived by major bleeding, which was less with the Watchman arm. The other important consideration here is that because we showed earlier that bleeding strokes were more common with warfarin, we know that those kind of strokes are more disabling. So stroke that happened in the Watchman arm were actually less disabling than stroke that happened in the warfarin arm, likely because there were less hemorrhagic strokes with Watchman. So now, remember, we said 3 randomized trials. We talked about the first 2, Protect AFib and Prevail. This is the third one that's called PROG 17. The first 2 were sponsored by the manufacturer of the Watchman device. This one was non-industry sponsored. And why did they do the study? Is because they said, well, first of all, we have more than one device on the market, so we should really study all of the devices as a class. And we now no longer use warfarin, we use DOAC. So comparing, the Watchman device to warfarin is kind of outdated. We need some contemporary way of looking at this. So they took patients who underwent left atrial appendage closure, mostly in Europe, by any device, and then compared them to those who received DOAC in a randomized fashion. There were 400 some patients who were high risk, randomized to both arms, and they were followed for 2 years, and then also there are 4 years late outcomes that were reported. As you can see here, the primary endpoint, which included stroke, TIA, systemic embolization, cardiovascular death, or bleeding, or procedural complications, were similar. So it achieved the proposed endpoint of non-inferiority, meaning that left atrial appendage closure as a class was non-inferior to DOAC treatment in high-risk patients in this trial. Now, people were concerned about procedural complications because that's very important. Obviously, whenever you have a new device, you start off with more complications. People build more experience, the device gets refined, and you have less complications, as you can naturally see in this slide here. So this is a US experience showing that with the first generation Watchman device, this is the rate of major complication. Any complication in the hospital was 2.4%, and the rate of pericardial effusion was also higher with the old Watchman device. All of those complications were actually halved with the newer generation device. Another important thing for people who practice in the US to know that there are now 2 commercially approved devices, the Watchman device, which is the most heard of, and then it's not really newly anymore, it's been approved now for almost 2 years, which is the Amulet device. The figure might be small, but you could see the Watchman device is kind of like a plug type device, while the Amulet device has two mechanisms of action. One is a plug, which is the lobe here, and one is a double closure, which is the disc that sits from outside of the appendage. This device was tested in a head-to-head trial with the Watchman of almost 2,000 patients, and it shows that there were no difference in safety endpoints between the two devices. There was slightly more closure with the Amulet device versus the Watchman device, mostly because there are a double mechanism of closing the appendage versus a single mechanism. So if you look at leak, any kind of leak around the device was less common with the Amulet device than the Watchman device. Lastly, efficacy, which means, stroke after you get the procedure, was similar between the two arms, 2.8 versus 2.8 with either device at 18 months. We recently published the largest experience with Amulet in the United States, over 5,000 patients, which were being treated in the first year of device rollout, and we documented the complication rates. We did see more effusions with the Amulet device, but that seems to be driven by operator experience. Because the device has two closure mechanism, it is more intricate to deploy and requires a little bit more experience than the Watchman device. Now, I promised not to overload you with trials, and I'm not going to go through these trials. I'm just putting them out there for you to know that there are multiple randomized trials now that look at, either increasing the evidence of efficacy or testing the use of Watchman with other procedures, such as pulmonary vein isolation, or optimizing the treatment after the device with, using dual antiplatelet or other things. And there are more trials looking at comparing left atrial appendage closure with DOAC in lower risk patients. I think between all of those trials, there are over 10,000 patients being randomized, and we anticipate the results of those trials to start coming in as soon as next year. Remember that question about the guidelines? So in 2019, hesitantly, the guideline committee endorsed left atrial appendage closure as a 2B indication. And you could see here at, that the level of evidence was low. And this is actually, there is a slight typo on the slide. This pertains to cardiac surgery, but the same level of endorsement was given to transcatheter. And I said hesitantly because they had a small footprint at the bottom of the guideline slide saying that we're only recommending this because the device is already approved and there is a randomized trial, meaning that maybe the committee wasn't yet convinced that there is adequate evidence to support the use of the device. Somehow that has changed in the most recent guidelines, 2024, in Circulation and JACC. You could read the guidelines and you could see that in high-risk patients, the left atrial appendage closure was upgraded to a 2A indication in patients who have contraindication to long-term blood thinners. The only difference between the first guidelines and the second guidelines is that Prague 17 randomized trial. So in terms of randomized evidence, there was one trial that emerged between the two guidelines sets, but a lot of evidence on safety of the devices has been published. Okay, so this is all good. We know that the device is safe. We have some evidence of efficacy, and there is more coming up. So what are other remaining issues with this therapy? In my opinion, the major problem is that some patients react to the device by forming a clot or a thrombus on the device itself, which is kind of counterproductive. You're trying to close the appendage so you get away with, clots. If a clot forms on the device itself, then that sort of like defeats the purpose. That's why I call this the Achilles heel of left atrial appendage closure. Fortunately, is not common. In different studies, the incidence of device-related thrombus ranges between 2% to 4%. It seems to be a little bit less with the newer devices, but still not zero. And when we talk about a preventative procedure, I think 4% is too high. And I think if we are to be certain that we're giving the best protection against stroke without, increasing the risk of major events, this risk has to go further down. We also know that if you do develop device-related thrombus, your risk of stroke, your risk of adverse event overall goes up several folds. So this is another 4% to remember. 4% chance of having a device-related thrombus. If that happens, there is a fourfold increase of stroke risk that was consistent across multiple registries. All right, so now, how can we predict device-related thrombus? This is a question that we ask and others have asked in the past. I think we have done the most comprehensive study by Dr. Samard, who was a fellow at that time. He's now one of our cath lab interventionalists at Mayo. We looked at all of those variables from baseline characteristics, anatomy, procedural factors, and even medications after the procedure to see what can pan out as a risk factor for device-related thrombus. We've identified those few risk factors and put them into a score that, called the DRT risk score. If you have more than one of those risk factors, your chance of having a device-related thrombus goes double in this study. Now, the problem is our patients are high risk. They're referred for this because they can be on a blood thinner. So predicting DRT is important, but since we don't really have a lot of options, it may be useful information, but not actionable. So the more important aspect is how can we prevent and mitigate the risk of DRT. And that is the reason, DRT is the reason why when the left atrial appendage closure field started, it was recommended that patients stay on a blood thinner for a few weeks, typically 6 weeks with warfarin after the device. Presumably that is adequate time for the device to heal and for endothelialization to occur, so you reduce the chance of thrombus. But as of 2022, the FDA sequentially approved a more abbreviated, or I would say maybe the better framing of that, a less intense antithrombotic regimen after left atrial appendage closure. So dual antiplatelet therapy can now be used depending on the device for either 6 months or 45 days after implanting a device without the need to using a blood thinner. So that's an answer to one of the questions that we posed at the beginning. If that's kind of prevention of device-related thrombus, how can we treat it? It's a thrombus, so you have to go back on a blood thinner. And that sort of dissolves the thrombus in up to 80% of patients. Unfortunately, in a few of those patients, the device-related thrombus would not dissolve with a blood thinner. It will either organize or get larger, that would require surgery eventually, but that's not common. The other concerning piece here is that sometimes you treat the device-related thrombus, but the predisposing factors haven't changed, so we treat it and it goes away with a blood thinner, but then it comes back once you stop the blood thinner. So you're sort of like committing the patients to long-term anticoagulation. If that's how you should think about DRT. If it happens, it's likely maybe up to 50% of patients you have to keep them on a blood thinner long term. Another remaining issue, so DRT was the most important issue in my opinion, even though it's infrequent, but its impact is high, and that's why I phrased it as the most important remaining issue. Incomplete closure of the appendage, or also called peridevice leak, is also an important issue. It is more common than device-related thrombus because the appendage has extremely variable anatomy and structure between patients and people in general. So that's why it is hard to get a 100% seal with a device that is, pre-shaped to go to all those different shape appendages. It is more common and it has different mechanisms. So it can be because you implanted the device with a little bit of tilt, or because there is a small lobe on the side that you haven't been able to get to, or because there is a fabric leak, which is uncommon. So this slide sort of like just illustrate the different reasons why some patients may have a small leak after the device. So an important question that was phrased very early on, you could see in red, I highlighted the year of publication, 2012. Up even 12 years ago when this whole field started, the question was asked, do leaks matter? And at that time, there's only one study, Protect-AFib, that was done, and analysis of that group of patients suggested that leaks may not be associated with problems, and it sort of went away for several years until more studies started just emerging as we have more and more patients now receiving the therapy and longer term follow-up showing, well, maybe leaks are not as benign as we think. In this study, even smaller leaks, if you follow them long enough, if they persist, they were associated with increased adverse event, namely strokes. This was then shown by us and others in larger cohorts. This is a survey of the national experience with left atrial appendage closure over 50,000 patients, in which we have shown that even small leaks were associated with small but statistically significant increase in ischemic stroke. If you put all of this data together from different studies and different trials, you come up with this conclusion that there is a small incremental increase in adverse event, not as much as device-related thrombus, but yet it's not negligible, and all leaks do matter, and we should try to do our best to mitigate those leaks and try to seal the appendage as much as possible. So, in summary, we talked about the background, the history of left atrial appendage closure, where it came from, how the unmet need was matched with an observation that thrombi form in the appendage, and maybe if we close it, we will be able to protect patients from stroke. The Protect-AFib, the Prevail trials were the first to show efficacy, then supported by the PROG-17 trial. Two devices then eventually became approved in the US, and this procedure is now incorporated in a higher guideline recommendation up to 2A. We do have a couple of remaining problems, but the two more important ones are device-related thrombus and peripheral leak, and there are more and more refinements of the device, testing of different medication regimens and other things that are being tried to improve those remaining problems. So now I'll finish by going back to the questions that we posed at the beginning. In randomized trials compared with warfarin, remember only two trials compared patients to warfarin, Protect-AFib and Prevail. Left atrial appendage closure was associated with lower rates of hemorrhagic strokes, but not ischemic strokes. Ischemic strokes were actually considerably higher, but not statistically significantly higher in the left atrial appendage closure arm. We talked about the guidelines and how they evolved from 2B to 2A in the most recent iteration. We also talked about how you now do not have absolutely to put patients on a blood thinner after the device. That's one of the common questions patients come with. Do we have to be on a blood thinner after the procedure? And even if it's a short period, sometimes they're afraid of going back on a blood thinner because of major bleed or some other side effect. So you can do DAPT for somewhere between 45 days and 6 months, depending on the device, based on the most recent update of the FDA labeling of the devices. And lastly, we talked about the remaining challenges with DRT and peridevice leak, and we have shown that even small leaks have a slightly negative impact on long-term outcomes. So all leaks do matter, and we should try to mitigate any kind of leak, but device-related thrombus remains the main problem with the procedure, in my opinion. So with that, I will stop here, Mandeep. I'm happy to chat about any questions from you or the audience.
Yeah, thanks, Mohammed. This was one of the most fascinating talks I've heard about the current status of early appendage closure. Let me start with my take on it. So if I look at it, it looks like that till date, we haven't been able to reduce ischemic strokes or all strokes, but the dent we have made with the LA appendage closure devices is the reduction in hemorrhagic stroke, which is, as you said, is pretty intuitive because these patients are not on oral anticoagulants. Would it be okay for us to then define this patient population better in terms of, because where the patients are getting worse in the oral anticoagulant arm are the patients who are given anticoagulants and bleed and have IC or hemorrhagic stroke. Those are the patients who have more disabling stroke rather than we are lowering their ischemic risk or ischemic stroke risk. How do you balance this with LA appendage closure device?
So if you look at the label, the FDA label when the device was approved, and the CMS guidance, it was kind of, I don't want to say vague, but it was broad. It says, because they followed how the trial was designed. They said any patient who is high risk based on a risk score, we use a CHAPS because is high risk for stroke, has non-valvular atrial fibrillation, and is able to take a short course of blood thinners because that was the recommendation initially, and has a rationale to seek alternative therapy to blood thinner. So that rationale can be, I don't want to pay for the medications, or it can be I had a bleed in the head, right? So it was very broad. So there was some concern initially about an indication creep and how people would be using it. But we looked at this in the national bases, and fortunately, people stayed the course and only included high-risk patients. So as of now, what we see in clinics is most of patients have had a bleeding events before they come for this procedure.
Mm-hmm.
So that by itself has happened. So they naturally selected and they referred for this procedure after a trial of blood thinner, deemed ineffective or they had a bleed. I would say maybe 70 to 80% of patients come with that problem. The rest, 20-30%, they're frail, they fall, they're using a cane, they're afraid about being on a blood thinner. But by itself, I agree with you that the current indication is for people who's exhibited a problem with a blood thinner. Now, there is a notion out there that no, when you restrict a potential therapy for the highest risk patients, you're depriving patients who may live longer from an effective solution. So why not everybody who has atrial fibrillation can use this instead of being on a blood thinner? Because blood thinners for 20-30 years in younger patients may have a lot of side effects and issues and cost. But that hasn't been proven yet. There are 2 randomized trials that are now coming to, and they finished enrolling almost a year or 2 ago, and we should have the results in the next 2 years. If the trials are positive, then you may see more, indication expansion to patients who don't have a bleeding problem, but the trials showed that they can be treated with either way.
Yeah, that's a major advance. I also wonder the newer devices may lower the incidence of peridevice leak, device-related thrombus. Those are determinants of future ischemic strokes as well.
Absolutely. I mean, we already see that the newer devices have made a pretty good strides and improved both the safety and short-term safety and long safety of the devices of those.
So do you think you've done it like you're one of the highest volume operators closing the LA appendage? Do you think in your own experience the complication rates, which to me I think the pericardial effusion rates are close to 5%, are they're pretty high in comparison to PCI that we do? Do you think with your experience these incidents of complications have gone down?
I think the 5% is like the very beginning. Now national data with the Watchman device, we're talking about a 1% range. So it is pretty low, and with experience, it's 0.25, 0.5%. So that's comparable to PCI almost nowadays. So I think that the effusion, in my opinion, the effusion is no almost no longer the problem. There are still, cases which we like to avoid, but it has become much safer than before. In my opinion, the more important aspect is to build more efficacy evidence and get rid of the device thrombus and the leaks.
So, are there any upcoming trials that are studying a combination of closure devices with some modification of antithrombotic or anticoagulant strategies?
Yeah, there are multiple of those trials. The problem is when the event rate is small, you need a very large number of patients to enroll in a trial. But there are a variety of trials now testing, for example, half dose DOAC after the procedure. Would that be the sweet spot where you manage the bleeding and the ischemic risk? As you know, in the surgical literature, there was a major study a couple of years ago in New England Journal of Medicine that showed if you close the appendage surgically and keep patients on a blood thinner, if they have atrial fibrillation, they do much better than those who were on a blood thinner alone.
Right.
So that's another evidence that actually it is true that if you get rid of this, space, you might reduce stroke risk. But what hasn't been clear is, should we actually think about that as a main strategy? Should we think about taking a blood thinner if patients are able to, and then closing the space as well?
Yeah, I think that bodes well with, because both CHA2DS2-VASc and HAS-BLED, they do not have a very high predictive accuracy in terms of determining who's going to have stroke or bleed.
Yeah, I'm happy to do a whole webinar about my feelings about CHA2DS2-VASc and HAS-BLED. But CHA2DS2-VASc in particular, we haven't really been close friends over the years. We've actually done a meta-analysis once, and we've seen that, first of all, the predictive capability of those scores are fairly low.
Right.
It's closer to a flip of a coin than certainty. But also we have seen that there was no difference in predicting stroke by CHA2DS2-VASc if the patients have AFib or not. Meaning that this is a vascular risk. If you think about what is in the CHA2DS2-VASc score, it doesn't include duration of AFib. It doesn't include left atrial size, left atrial appendage, morphology, physiology, all of those important factors. It has clinical variables that the same risk factors for any kind of stroke.
Yeah, I think that determines high risk patient rather than for anything.
Yeah, rather than AFib specific
Right.
strokes.
So how do you, one of the viewers has asked, how do you do surveillance of these patients after a device is deployed?
Yeah, good question. So as of now, the current guidelines is you should do at least one imaging study after the procedure. So we do CT scan or TE within 45 to 60 days after implant. We do like to have a second one at 1 year. Some of our patients come from a distance, so we can't really get that all the time, but our current practice is to do one imaging study at 45 days and one other one at 1 year.
So do you differentiate the timing of surveillance depending upon which device you put in, or is it a standard?
No, it's standard. It's similar.
Is there a time relationship between complications such as DRT or peridevice leak? Is there a time course that are they time dependent?
Yeah, so very good question. DRT is mostly a first year problem. Okay, you get most of the DRTs happen within the first year. Leaks too, but the impact of leak only shows up later after years. So DRT, which is the more associated with more higher folds of adverse event, it manifests within the first year.
So have you no, it's not that uncommon. Have you looked into patients who've been re-put on OAC after the detection of DRT? What are the recurrent hemorrhagic rates on these patients?
Yeah, good question. We surprisingly, because it's a shorter period of time, typically you put them on 3 to 6 months. We haven't seen major bleeds as much as.
So that's a good strategy to do, right? I mean, even in patients who've bled in the past, may not bleed again, even if you re-challenge them with DOAC.
I think we have we should do a better job in really understanding bleeding, because we just use it as a blanket statement.
Right.
But bleeds are different, and if you talk to the GI people, they don't really believe that DAPT is much better than blood thinners for GI bleeds. They think DAPTs are almost as problematic, right?
Yeah.
So, and then there were a few cases at the beginning of the experience where the bleed is uncertain, like where is the bleed source, right?
So the other question is, when you said mitral stenosis 50-50, do you include all degenerative mitral valves, or you just specifically exclude patients with
Yeah.
traumatic mitral stenosis?
I would say this is supported by quasi-science, not really solid data. The current recommendation is if you have a gradient of more than 5 in the native valve, whether it's traumatic stenosis or calcific stenosis, that is considered, valvular atrial fibrillation. A common question that comes is mitral regurgitation considered, valvular AFib, and the answer is no. Indeed, somehow mitral regurgitation is protective against stroke because you have these high velocity jets kind of washing the left atrium and the appendage. So we've seen it sometimes when we do edge-to-edge repair on the mitral valve.
Right.
We've seen within a short period of time, people start having clots or smoke in the left atrial appendage because there was a washing jet. So as of now, the bioprosthetic valves are uncertain. They're not typically considered valvular atrial fibrillation. It's typically native mitral stenosis due to traumatic or calcific reasons. But if you could think about it intuitively, if you have a bioprosthetic valve and it degenerates and it causes a high gradient, it's the same kind of process, right?
So do you look at presence and extent of atrial myopathy in selection of patients when you close the appendage?
No.
Okay. I think that must be something that
Definitely, yeah. I mean, that's again, I don't want to go back to the chat VASC, but our approach is all derived by, let's use a simple inaccurate score.
right.
But an atrium that is this big or an atrium that this big, if it for 10 minutes or 10 years is all viewed similarly by chat VASC, right? But we know that's not true. There are enough studies to show you that the longer AFib duration AFib you have, the more adverse events you have,
Right,
and the
right.
more atrial myopathy you have, the more strokes you have. So, but as if the whole field is guided by simple scores and not incorporating physiology and anatomy, the small part of the appendage closure is just following the mainstream
Right.
pathway. But it matters in one sense that if you have a lot of remodeling, sometimes the appendage is too large to be closed.
Yeah, because all the decisions that we are making for LA appendage closure are totally based on these inaccurate scores, both for bleeding and stroke.
Yeah.
And that must be limiting the
Super
power of
right.
the studies too as well. So one other question, which is kind of interesting, and I also had it in mind, and you've been involved in this field, is artificial intelligence. So how, if you are incorporating the information you can have from artificial intelligence in not only selecting patients, but also device selection and surveillance of these patients?
Yeah, good question. So I think there are two components here. One, in terms of optimizing the procedure and device selection, implant optimization, all of that. We do use computational modeling, and we can do virtual implants and see how the device would look, and that guides our selection. We have that service available at Mayo, and we use it, deliberately to optimize the procedures. So we rarely now reach out for a second size device. Typically, what we predict on the virtual implant is what we see in the procedures. So the procedures have become much more streamlined, quick, and efficient using AI. Computational modeling does use AI in the background. But the other more important component, which has to do with your question about risk prediction, I believe that there should be some sort of an imaging modality incorporated in risk scoring. And but that adds another layer of complexity. But pick a study, echo, CT, whatever it is, and then you get that CT or that study, you apply AI modeling on it to extract a ton of information from it. You add it to your clinical risk score, and you come up with the best prediction possible of, ischemic stroke risk. That has not been done, but I think it should be because we're still, guided by a historic low performing score.
So what would you use AI for? Is it the patient variables? Is it the ECG?
Well, it's
Is it
mostly all of the above, but I think the highest value would be from the imaging, because you could use it from ECG. As you know, our group has published extensively on predicting different things from ECG. So there's always more information in the studies that we get than what the eyes tell us. So if you apply AI, then you get extra information from the ECG, extra information from the imaging study, combine it with the clinical risk factors, and come up with a good score.
Yeah. So when you perform, one of the viewers is asking, what kind of imaging do you use in the cath lab? Do you use ICE? Do you use TE?
Yeah.
How do you do it?
So, as I said, they're only really you could use none, but that's not a common practice. Most people use one of the other. So they either image from outside with the TEE or from inside with the intracardiac echo. Now, for years, we have switched to almost 100% intracardiac echo in our practice.
Is it the definition that is better with this, or is
No, actually, there is a little bit more learning curve with using ICE.
that's what I thought?
But now we have 3D probes and probes that can give you similar, not identical, capabilities to TEE. But it's not the definition, it's just how logistically, how much better it is to use ICE. You avoid general anesthesia, you avoid intubation, you avoid, the putting the probe in the esophagus. Patients can go home same day, where our rate for same day discharge now is up in the 70-80% because of that. So it really becomes almost like an outpatient kind of thing with using ICE. So we've switched to that in the vast majority of patients.
Very nice. Last question I have on my plate is, now you've done it since the inception of this procedure, I assume, right? So you being a leader in this field, what do you think the next 5 to 10 years will bring this innovation to us?
Yeah, so currently there are 2 approved devices. There are probably another 20 being tested. There could be potentially a winning device that leaves less footprint in the body.
So do you think like a bioreabsorbable kind of
So that has been tested, but there are now devices, for example, that go in the appendage and twist the appendage on itself and almost closes the neck to a negligible size, and you just put a tiny plug on the neck. So that's one promising innovation that has
They
been.
did this the pericardial thing to the lariat one.
Yeah, going pericardially to lasso and
Yeah.
hang the appendage has been tried. And it's effective, but it's very cumbersome, and the complication rate wasn't acceptable with, compared to the endovascular devices.
Right.
I don't think epicardial left atrial appendage closure, at least percutaneously, would be successful as a scalable strategy.
What other things do you think will?
Yeah, so I think newer devices that have less footprint in the
Right,
heart
right.
will come. There are devices now that use drug coating, similar to drug coated stents, because it's the same problem, right? We have bare metal stents, device thrombus, same thing here. So we actually the newer Watchman Flex Pro device has antithrombotic coating that we use now. There are more studies now being run to see how effective that is in reducing device related thrombus. But there will be more iterations of that in the future. And I think a big thing in the future that's happening is combination procedures. So
What do you mean?
you're coming for left atrial, you're coming for mitral clip or something like that, and you're already there. If you were doing surgery on the mitral valve, you would close the appendage, right?
Right.
So we also ran a proof of concept study here where we did combined procedures in 25 patients and shown that it's feasible, it doesn't add much time. So patients who are eligible for more than one interventions, can we combine them together? That is even the larger scale is with atrial fibrillation ablation. A trial has already been completed combining appendage closure with ablation, and there is a good chance that might get approved for a combo procedure. As you know, in our field for many years, we're always being told do one procedure at a time, but maybe the times are changing, and if patients are eligible for a combo procedure and it's intuitive that you're already in the left atrium, why do you bring them twice? So I think we'll see more of this one-stop shop kind of approach in the future.
Very nice. I think to me, having done risk prediction modeling, one thing that I think if I would add would be better selection of patients in terms of identifying their stroke and bleeding risk. I think would complement to the advances that you just mentioned. I think this is a fascinating field, and it will change how we think about the LA appendage and the appendage closure in the coming years.
Absolutely.
All right. Thank you, Mohammed.
Thank you very much. It was a
Thank you.
pleasure.
Thank you,
Thank you all for being with us today. Have
Yeah.
a great
Thank you,
rest of your
everyone.
day.
We'll sign off. Thank you. Bye bye.